thank you everyone for coming tonight to the My Epilepsy Story We Care series. My Epilepsy Story was started in 2013. There was nothing out there specifically catered towards women and girls with epilepsy, and a group of doctors and myself, Brandy Parker McFadden, we started My Epilepsy Story to really change the way that medicine is happening for these young females, as well as adult women. We believe in empowering these females, and we believe that's the only way that we can change the long-term impact of epilepsy on their lives. So you can visit our website, which you've probably already seen, but it's www.myepilepsystory.org, and also follow us on Instagram and Twitter. If you are on any of those social media platforms, you can go ahead and tweet about this throughout the evening. We want to share as much as we can. This is an educational seminar that will be recorded, and we will eventually put that up online. It will only be for medical professionals to access at some point. And we are very thankful that we have Nationwide Children's Hospital that have sponsored this event for us, and a very amazing doctor that I've known for many years now. I'm very thankful that he is accepted to be a part of this wonderful process. He's been involved with My Epilepsy Story for quite a while. And so I'm actually going to introduce you to Dr. Sarita Maturo, who's actually a neurologist and actually a board member here at My Epilepsy Story. And she currently practices at the Ohio State University in Columbus, Ohio.
Thanks, Brandy. So it's an honor to introduce Dr. Anup Patel. Dr. Patel is a board-certified neurologist with special qualifications in child neurology. He's also a board-certified in epilepsy and clinical neurophysiology. He's the president-elect for the Child Neurology Foundation and an associate medical director for quality improvement at Nationwide Children's Hospital. He's also the director of quality improvement for neurology. Dr. Patel is an associate professor for neurology and pediatrics at Nationwide Children's Hospital and Ohio State University Western Medical Center in Columbus, Ohio. His journal publications and clinical research interests in the field of pediatric epilepsy, healthcare utilizations, learning healthcare systems, and quality improvement. And finally, like Brandy said, he has worked with My Epilepsy Story for many years in the quest to empower young females. So with that, I'll give that to Dr. Patel.
Thank you for that kind introduction, and thank you for all for participating today. So I am going to get my screen up and we're going to get started. 1 second here. All right, can everybody see my screen? Probably can see my email. Let me switch it. Okay, can everybody see my screen in presentation now?
Yes, good to go.
Perfect. All right. Well, we are going to get started, and I would really want this to be an informative talk, but more importantly, I really want to advocate for how important it is for women with epilepsy and these issues as it relates to transition. And real quick, I'm actually going to switch, and I apologize for this. 1 second. This is told Brandy how good I was at this, but now unfortunately I'm not doing as well. So I apologize for that.
No, you're fine.
All right, here we go. All right, that's who I am, which we talked about, and I don't have any disclosures as it relates to this presentation. So when we talk about transition, I really want to make a huge point in definition that it's really not transfer of care. Okay, so that's the last step in the transition process, but it's a journey, and it's a journey that we're going to talk about today as we go through the steps and the importance as it relates to both men and women with epilepsy. But I'm also going to highlight some of the areas that I feel are super important for women with epilepsy. So when we talk about transitions, there's a lot of work from a lot of different organizations that have been involved at this for a lot longer than us in neurology and in epilepsy have been in specifically. And so some of the work that we're going to talk about is going to highlight those. But one of the things I think it's important to highlight, because it affects those with epilepsy, is separating between those that have intact intellectual ability and those with developmental disabilities. And it's really important that we work on transitioning both populations effectively and efficiently over time. So our goals for transition are really listed on here, but I'm going to focus mostly on high quality because we really want this to be a high quality process. And why? Well, you can say, well, because a lot of other organizations have got behind it, including, the one that I'm going to enter as a president-elect for the board of directors, the Child Neurology Foundation, but it's really not about the organizations. It's about why these organizations felt it was really important to give a stepwise approach and guidance for transitioning of all patients in the medical field. So when we look at transition, we're going to talk about 6 core elements. And really why these elements are important are they've been really well vetted through different organizations. And really, if we follow this process, we're going to do it successfully and have an outcome that will be both advantageous for the patient and for their caregiver or parent. So the timeline that's been recommended by the GOT Transition organization is really listed in front of us here. It doesn't mean that you have to follow your transition process the same way, but here's a guidance or model that can be followed. But each individual organization and institution has to follow their own model. And these are just guideposts that can be used for how you're going to develop your system of transition moving forward. But why else should you do transition? If it's not important enough because it's the right thing to do, let's look at some of the data as it relates to what happens really when transition is not done successfully, or perhaps when we have an opportunity for improvement. And when you look at it, I'm going to talk about a study that I feel is still really pertinent, even though it was published in 2008. And really what they found was that it was a very difficult process for those that didn't get transition at this time as it relates to increases in ED visits and hospitalizations, but we'll talk about that. So on this graph from that manuscript, you'll see that the biggest thing I want to highlight is that group in the middle. And when you look at that from the left and the right, you'll notice that those that in that transformative years of adolescence do see an increase in healthcare utilization during that time. And specifically what you see is really an increase in admissions, and those are associated with those that did not have a documented transition plan or any evidence in the medical record that a proper transition actually occurred. So it's really an important thing for us to be able to highlight. So why is it important as it relates to epilepsy? Well, I know that this audience understands epilepsy, both pediatric, adolescent, and adult epilepsy, but it's important that we understand and pause to say really why it relates to what's important for our specific specialty and care interests. And really, it's because there's a gap, and there's a gap not only in our field of pediatric epilepsy, but likely in many other gaps. And we'll talk about that specifically as it relates to both in the neurological fields and then obviously outside. But one of the things that we realize and learn is that parents and families get very accustomed to what they've gotten as far as care from their pediatric providers, right? They've often been with us for many years since they first started having seizures, and those relationships build with a bond that carries over time. So it's very difficult that once that process of transition begins, because that bond has to be completely severed in some cases, because that's the perception that these parents and caregivers and patients sometimes feel. And we as providers in pediatrics can do a better job of trying to smooth that, but it's still difficult. Now, it also is difficult for us because we as pediatric providers sometimes don't do a nice enough job to empower our adult colleagues. We're very lucky to have Sarita on this call. Sarita is part of our transition clinic with the partnerships at the Ohio State University. And Sarita is a champion. Sarita and her colleagues are a champion because they are willing and able and wanting to learn how to do this effectively. And they've had to take on some very challenging patients. But because we now have a process and it's not a one-step end process, it's now been a better one and one that can improve over time. And she's very instrumental with that process. Oops. The other thing I want to highlight is, don't forget, a lot of pediatric or epilepsy starts in the pediatric era, but it's not just identified as seizures or increases in seizures, right? We have to worry about all those other things that are associated with epilepsy. And again, these things start in childhood, develop into adolescence, maybe change in that adolescent period, and then again change perhaps in the adult period. So we've got to be very cognizant of that. The other thing, and I know I mentioned that, is really there's a lot of aspects or a lot of categories that we have to be very careful of as we transition our patients, which makes our field of pediatric and adult epilepsy maybe a little bit more unique than some of the other fields that are working on this transition process. Then we have to talk about some of the outcomes that we're trying to prevent, right? SUDEP. First of all, what is SUDEP for those that are maybe not as familiar? Sudden unexpected death in epilepsy. And what do we know about SUDEP and SUDEP risk factors? Well, obviously those that have generalized tonic-clonic seizures are increased risk, or perhaps not taking your anti-seizure meds on time, or changes to your anti-seizure meds. Well, in a lot of cases, those are our adolescents, right? Seeking independence, autonomy, identity away from this thing called epilepsy. And so I think it's really important that we remind ourselves of that. And if we don't transition, or again, prepare our patients or adolescents through that transition process, then we may be failing them in more ways than we would ever hope. The other thing we have to remember is transition involves other lifestyle and coaching opportunities, right? Teenagers like to experiment, and sometimes they drink alcohol. I know that's a shock to many of us on this phone call, because we would never have done the same thing. Well, the consequences as it relates to epilepsy are grave and deeper, because they have to understand the risks and increases in potential seizures or lowering of seizure threshold that can occur. What about women with epilepsy? As Brandy said, I really love partnering with My Epilepsy Story and find it's a great organization, be able to empower women with epilepsy, and it's an opportunity for us all to be involved. And there are issues or specific areas that have to be focused that are related more to women that maybe are not associated as far as men goes. And those are really around counseling for the need of folic acid, around contraception and possible medication to medication interactions that can occur with contraceptive care, counseling around family planning, pregnancy, and breastfeeding. And these are very important issues. The other thing I want to highlight are the important issues around developmental disabilities. So people often ask, because my clinic population, as Sarita knows, is treatment-resistant non-surgical epilepsy, which means I have a larger percentage of my patients that have developmental disabilities. Do I counsel them the same way I counsel those that have intact ability? Absolutely. I do not make any judgment or provide less care for these women than I do any other woman or person in my practice. They deserve, in my opinion, the same counseling and recommendations. Then it's up to their caregiver to decide whether they should go forward with that recommendation. Again, not my place to judge. The other thing I realize and recognize, and one of my colleagues, Dr. Jamie Twano, who's really the champion of our adolescent transition efforts in epilepsy, has showed both Dr. Kulkarni, who's on this call, and I, is that perhaps folic acid or multivitamins are important for all patients with epilepsy because of the bone density, the potential benefits of taking multivitamins. So maybe, in fact, we should change it and say, you know what, we're going to recommend this for all patients, and especially those with developmental disabilities that may be at even higher risk for bone density or other complications. And again, it's our place to provide the counseling, but it's the caregiver's place to decide what's best for them and their family. And then obviously, more importantly, the woman or the male adolescent patient be involved with that care if possible. So around the idea of counseling, I want to go back to that because that's such an important and really life-changing potential concept that I think is important to highlight in specifics. So the American Academy of Neurology, which many of you know I do a lot with because of the passion I have around these quality issues, developed a quality measure around the idea that counseling should be done. And really what a good quality measure is that, look, there's evidence that's out there, but for one reason or another, that evidence is not being implemented to the highest degree of possible. And that's really not to say somebody is providing poor care, but that's just an opportunity for us to know where we are and where we want to get to as it relates to certain things that are important in the field of pediatric and adult epilepsy. Well, some others have looked at that as it relates to transition. And I want to talk about some of those studies because it's really important, because some of these are what has been found in our field of neurology and in epilepsy. And they found that education for the family should be improved, and that identification of social and psychiatric complications can really help, and sometimes are missed during that transition period, and so should be part of that care. And the more we do at the front end is going to make it a lot easier during that transition period. And then more importantly, when that patient then transfers their care to adult providers, those adult colleagues do not have to pick up a ball that was not previously started. I think in a lot of ways, our adult colleagues are probably better at the management and the comorbidities than we are in pediatric epilepsy to some degree. And so I think there's some learning opportunities that can be achieved by partnering with our adult colleagues like we've done here at Nationwide Children's. The Camfields have also published in this area. So Peter and Carol Camfield out of Nova Scotia, Canada, looked at that, and they were actually one of the first colleagues to actually look at this field as it relates to pediatric neurology and pediatric epilepsy. And really what they found was exactly what was mirrored around other disease states, that really, you should do it. There are obviously some great outcomes that can be achieved if you do it properly. And it's an important topic for us all to focus on. They also looked at the stigma and some attitudes that are associated, unfortunately, with our disease, and what transition could potentially offer as far as minimizing those as you enter the adolescent and go into adult phases or adult ages. And so really it's important. Unfortunately, at the time of their study, there was really not a lot of objective evidence of what models worked in our field, but subsequently some work has been done, and I want to highlight that today for you guys later in this presentation. Let's talk about the gap. Remember, I told you earlier that it's important when you have good evidence that something should be done, that you should do it. But a quality measure is really that there's a gap there's good evidence that something should be done and a gap that it's not being done. And if you look at that in our field, it's really true. More than 25% of young adults with treatment-resistant epilepsy actually never see an adult neurologist or epilepsy provider. And that's not to knock on primary care providers, but obviously there are some inherent opportunities and things that we do as neurology and epilepsy providers that perhaps can't be done in the primary care world. And if we do a better job with transition, then we're going to be able to lessen that gap, and less percent of patients with epilepsy are going to not be seen by adult colleagues. What about adult epilepsy in neurology? Well, one of the hardest parts is because some of these diseases and syndromes are challenging, we aren't preparing, and I highlighted this earlier, some of our adult colleagues the right way. So I take it upon some of the adult colleagues to have reached out to us for more education opportunity. Again, I don't want this to be about how awesome Sarita is, but she really is in the way of reaching out across the lines to say, hey, listen, I really want to provide the best care I can for these patients. How can you help me? Because you have some experience and have taken care of these kids for a long period of time. And so I really highlight that opportunity for others that perhaps see adult patients to do the same and learn that. And hopefully today's presentation will help you a little bit. But it's important that we all have an understanding of newer treatments and other options that could be present for our patients, such as epilepsy surgery. Unfortunately, you're not going to be able to get those things in certain primary care worlds. Again, not because primary care providers are poor, it's because they're not poised or positioned for a proper understanding of all the nuances of complicated treatments that occur in our field. The other thing I think it's important about adult providers is, again, those comorbidities. We can't just be living in a bubble of isolation that epilepsy or seizures is the only thing going on with our patients. So that multidisciplinary approach that we often adopt in the pediatric world should be carried forward in the adult world as well. And unfortunately, a lot of resources are not present for our adult colleagues. And so we got to partner and work with them to help them help their administration understand the importance and need of that. What other barriers? Well, there are a lot of other barriers that I mentioned. I mentioned the lack of preparation we give our adult colleagues that lead to perhaps some lack of confidence in managing some of these patients. but then actually the knowledge and understanding amongst the patients and caregivers. And so we're going to talk about how we can empower our patients, and more importantly, for those patients and caregivers that are on this call, how you can empower yourselves, be that advocate that then translates to success as a team. So the American Academy of Pediatrics recognized this many, many years ago and recognized the challenges between communication and also the need for education and proper time of when to do this. And so those are all barriers that they identified, and how we are able to overcome them will be a testament of time moving forward. So what tools are available as it relates specifically to neurology and epilepsy? Well, at the Practice Management Committee many years ago, the American Epilepsy Society developed some tools that can be used to assess patients through that transition process, really a roadmap of when and how to do transition. And they did separate, they have a separate process or roadmap, so to speak, for patients with developmental disabilities, because there are some unique challenges and unique things that should be discussed during the pediatric epilepsy time that are inherently part of patients who have developmental disabilities. And those could be things around guardianship, job placement, etc. The Child Neurology Foundation also has great resources. So prior to my involvement with this organization, there was a great transition work group that was put together in a task force that developed some great resources and instruments that can be used both for providers, patients, and caregivers. The other one I want to talk about is a study that I partnered with my colleagues at the University of Michigan called EpiTrack. And yes, we do here at Columbus, Ohio, and at The Ohio State University, participate and also work well with those folks at that state up north. Now, what are the goals of any tool? Well, the goal of transition tools are really to make the process easier, but it also involves our adult colleagues. And so being able to actually use them as partners in our process is going to be paramount for that successful transition. In our model locally, we have our adult colleagues and providers join us in our pediatric epilepsy clinic to see that patient for that one time before they move over to their institution. That may not be a feasible model for everybody, and I recognize that. So now in the advent of telehealth, I ask everyone out there to be thoughtful and think outside the box of other opportunities that can involve direct contact with your adult providers, so proper communication can occur during this transition period. What tools are related for specifically to epilepsy? Well, again, I highlighted that study we did with the University of Michigan, and they developed this tool called EpiTrack. TRACK was actually a transition readiness assessment questionnaire that was developed and validated by colleagues across the United States. We added some epilepsy specific questions and revalidated this questionnaire to be sure it was capturing and also properly implemented for those adolescents during that transition period. And what we learned was that it works really well. So it's a tool that can be used, but by no means the only tool that you should think of. gottransition.org also has tons of resources. And again, Child Neurology Foundation and AES has those as well. So where are there opportunities for improvement and areas where we should focus on? Well, we're talking about women with epilepsy, and I think there's really an importance as it relates to counseling and for folic acid. So the current quality measure that I mentioned earlier, it's really related around processes. So did I perform counseling, yes or no? And was that counseling adequate? But one of the biggest barriers we've had is, does that counseling lead to improved outcomes? So for example, one of the questions we wanted to ask locally was, if we were to provide counseling around the importance of folic acid, did that mean that more women with epilepsy would get or take folic acid? And hot off the press, because I just got this data today and we reviewed it with our team, the answer is yes. There's actually a twofold increased likelihood that if you provide counseling during your office visits with your patients, they are twofold more likely to take and be on folic acid. So yes, counseling does matter. There are other areas that both colleagues here at Ohio State and at Nationwide have been working on, and that's really around seizure action plans, one of the greatest champions of epilepsy is Lucretia Long, and she's at the Ohio State University, and she's been a champion around seizure action plans and trying to implement them in the adult population, but also rescue meds. And that's also been a champion effort by Lucretia. And we have done that also locally with our efforts with Dara Albert, one of our pediatric epilepsy colleagues. But being able to actually track your progress, identify your gaps, and improve your knowledge over time as it relates to some of these opportunities and maybe more are really important as you move forward and develop your own transition programs. What about some other ideas? Well, I mentioned psychosocial issues and how important it is for us to screen and understand if those exist in our populations, both in pediatric, adolescent, and adult populations of epilepsy, because that is a real issue and it's only getting worse during this pandemic. So Gerling and their colleagues said, you know what, more attention should be made, especially during those periods of transition. Well, you know what, we're all busy clinicians. We're all trying to get through our day. I get it. So how can you do this, even though we know how important it is? Well, I want to really give you an opportunity or a way of potentially doing that. I am a huge champion of quality improvement that many of you know, and I also love to institute quality improvement projects. And many of our successes, both locally and nationally, have been because of our work around quality improvement. We at our institution use the Institute for Healthcare Improvement, and that's really based on this triple aim that's listed here before you. But again, by no means do you have to use this model of quality improvement, but I'm going to talk a little bit more about that as it relates to our group and the work we've done. So why use QI methodology? Well, guess what? Outcomes do exist and can occur if you do transition better. You can design them around a patient, around a healthcare system, or around your community. And this methodology can be implemented in all of these areas and more. But most importantly, it's about working together. We are one team. So the adolescent, caregiver, and medical providers all must work together as one team. My good friend and colleague, Jennifer DeSabato, who's a nurse practitioner at University of Colorado, or Children's Colorado in Boulder, Colorado, did this, or Denver, Colorado, I'm sorry, did this great study around looking at using quality improvement as it relates to transition. And what she really did was try to make this on the first appointment for patients with epilepsy using self-management education. She used the electronic health record to trigger those patients that were in need of potential transition, and then empowered them through these self-management educational modules to be more successful and empowered with their transition. What they found was this process helped shorten the time of referral to their adult colleagues and showed the benefits and use of social work for assistance as it relates to this process. She was able to advocate successfully for additional social work resources, not only in the adolescent clinic, but also in her adult colleagues' clinics. So let's talk about the roles, and I'm going to break it down based on each team member. So adolescents, we want them to be knowledgeable. You be knowledgeable about your own epilepsy. Ask questions to your providers. Take ownership of your future. Do not let epilepsy stop you. If you have any other questions around that area, see all the great resources on myepilepsystory.com, because there's a ton of great resources that will help empower you for your epilepsy. What about the caregiver? Well, you got to help with that knowledge. The gap is there because we have to make sure as medical providers, we're providing that education. Be patient with your teen. How many times, for those that have parents of teenagers, which I now am one of those, have to learn this every day. Be patient. But you also have to slowly let go, which is one of the most difficult things for our caregivers to do. We must try to instill independence where possible and promote that independence amongst our adolescents with epilepsy as they move into the adult ages. And most importantly, we got to continue to advocate. Advocate for your child, advocate for your child, advocate for your child. Your child is always your child, even when they become a young adult. And so we must continue to advocate for them. What about us as medical providers? Well, guess what? We are responsible for starting that process. It's on us. So we got to make sure we have the right resources, the right staff. We have to have our own education, and you're taking a step in that right direction by listening to me today. Provide educational materials. Don't recreate the wheel. Don't feel like you've got to learn and do this on your own. There are, again, lots of resources that I mentioned. Borrow and steal. It's a great concept in quality improvement. So for women with epilepsy, don't forget that prescription, or don't forget to talk about folic acid and the importance of it and how it can help when people and women start family planning. And then work with your colleagues, right? Even in adolescent medicine, I want to talk about that. And I really want to talk about where perhaps we as medical providers in pediatric neurology and pediatric epilepsy can take a leap forward and a step forward to provide women more important aspects of their care that perhaps are in our traditional viewpoint. I want to talk briefly about an effort around that initiative. Contraceptive Access Collaborative is an effort led by one of my, again, friends here locally, and huge international advocate and international expert in adolescent medicine, Elise Berlin. And she's really led a great effort around creating opportunities for other subspecialties and disciplines to work with her and her colleagues on really improving counseling around contraceptive care, and perhaps having a better understanding of which contraceptive care methods are best for our patients. I'm proud to say that that collaborative has been joined by neurology and is being led by one of my colleagues who I'm very proud of, Dr. C.A.R.E. And our goal with this collaborative and our efforts with our adolescents colleagues are really first to be better at giving counseling, be better at giving the folic acid and the importance of that. And we're trying to do that really and instill those habits with all women 12 years and older, because that's when things become started to solidify, right? If I develop those great habits as an adolescent, I'm likely going to carry them into adulthood. But then why not work on giving good information on contraception, and also really referrals when needed? I don't need to become an expert on around what contraceptive methods are needed, or do I need to prescribe those medications when I have such good collaboration with my adult colleagues. But my colleague, Elise Berlin, is never going to know about my patient unless I make that referral or talk to them about the importance. And we, because we see our patients so frequently, are really champions, and people listen and look to us for guidance. Our global aim is to reduce unintended teen pregnancy. And I know many of you may laugh at me for that idea, because why would a neurologist care or should focus on reducing unintended teen pregnancy? And I'm here to tell you the reason why is because it's important to all women. And we're not just champion of women with epilepsy, we're champions of women in general, and therefore have to be able to advocate for them on any way we can. If a teen does not want to start their family during those teenage years, then we should help them for that, because epilepsy is hard enough to manage on their own. And then having to start and work on having a family is kind of something that they need to prepare and do on their own time and when they're ready. The other important thing is those issues that can occur when we do not properly educate our families or our patients around the importance of folic acid and the impact that certain anti-seizure meds can have on on children born from adult patients. So you're all sitting here saying, gosh, this is all great. I really want to do this. How do I do this? Well, I'm going to walk you through an example for you guys just to consider and see what can be done. I'm not going to go through the specifics, but I want to break it apart on what we're doing locally. And as of tomorrow, this new assessment tool will become live in our own electronic healthcare system, because we've worked on it in a group here at our institution involving multiple disciplines around the hospital, because we now know that there are certain aspects that can be done universally among specialties. And then each specialty can take those those broad areas and provide unique factors that I mentioned earlier as it relates to our field of pediatric or adult epilepsy. But really, you have to start to bucket it around these areas, learning about your own healthcare. So how we help empower our women with epilepsy around understanding their interests or issues as it relates to their own epilepsy, but more importantly, broadly as it relates to their healthcare. And then there's a management aspect of healthcare. You know, our families and our patients must know what happens when they turn 18, as far as healthcare privacy, HIPAA, ownership of records, et cetera, medical forms, medications, prescriptions, refills, et cetera, et cetera. Talk to your families and ask them. If you ask your adolescents these questions and they don't know the answers or can't accurately answer where you feel comfortable, these are then opportunities for you to educate. By no means are you going to have to focus on every aspect, because there is likelihood that some of these questions they're going to know the answers to or be able to feel comfortable with. But where they don't, that's where we come in or provide those resources. Then it's about managing that actual healthcare. And that's really where that transition is going to start to focus on as it relates to those final steps before they move on over to our adult colleagues. And those are big topics that we don't necessarily think about, nor do we teach our teenagers. Where are you going to live? How do you make your own appointments? Do you know where to go for emergency care? What's your health insurance? What's your plans for that? These are things that you don't have to have all the answers for right away, but you should start introducing as that journey evolves. And then you're getting to the point about being almost ready. And this is where you're getting close to that last aspect, which is the transfer of care. Remember, there is nothing I talked about thus far because relating to transfer, because transition does not equal transfer. Transfer is that final step when we do have them go see our adult colleagues. So again, those are some things that you may need to tailor as it relates to your specific patient or patient population, but please allow yourself to do that. But here are some broad topics that can be considered. Let's go into detail a little bit more and in summary about related epilepsy issues. So for all of us, know the importance and issues around folic acid and why it's important that our patients or women with epilepsy are counseled on taking folic acid. Know what drug interactions or medication interactions occur between anti-seizure meds and contraceptive care. We are prescribing the anti-seizure meds, so technically we're responsible for the interactions that may exist with their contraceptive care. Well, if we don't even ask what they're doing as far as it relates to contraceptive care, how are we going to know that? And then also know the aspects of what epilepsy can do for pregnancy and vice versa. You know, many in our field of pediatric epilepsy do not feel comfortable talking to adolescent women or their parents about things like pregnancy, family planning, breastfeeding, et cetera. And I recognize that's not a topic that's often front of mind for us, but it's also important, like I mentioned, that we start those conversations early. We're not advocating for anyone to get pregnant. That's up to them and their families. We're just here to provide that information and have them give and have a full understanding of the effects of epilepsy as it relates to both, again, the pregnancy and vice versa. Also, just have a broad understanding. If you're a pediatric neurology or an epilepsy provider, I'm not saying you have to understand the effects of anti-seizure med on breastfeeding, but it's not bad to know those things and really have that information. And I'll be honest, that's not a topic I'm even familiar or too comfortable with. So it has to be updated or at least gone over year after year. And then also focus on a seizure action plan. You're going to start to see more emphasis and importance placed on seizure action plans for both adolescent and pediatric, but also our adult patients. And so really start thinking about that as it relates to your patients, specifically during that transition period. One of these days, I would love it to where when they got to see our colleagues at Ohio State, that all our patients had seizure action plans and that they're followed or changed over time with their adult colleagues. So in summary, epilepsy providers, we can serve as a role model for how to properly transition patients into the adult ages and to our adult colleagues. Partner with your adolescents, partner with your caregivers so you can lead to better successes. Because remember, we're all one team. It's a team effort. And more importantly, transition is not transfer. Do not feel you've done a nice or good enough job with transitioning if you haven't followed some of these steps and asked these questions or assessed where your patients are in this journey, because that is not proper transition. And then you're not doing anything to help that patient, their caregiver, and also your adult colleague. So I want to say thank you. I want to say thank you for your time today, your attention to my epilepsy story, to Brandy, to Sarita, to Neil, to Jamie, to Dara, to Whitney, who's also on this call, one of our outgoing residents who I'll miss dearly. These are all champions of not just epilepsy, but women with epilepsy. And I think that's a hugely important area and one that we can improve upon nationally. So with that, I'll turn it over to any questions that you may have. And then at the end of my presentation are also references in case you're interested. So thank you for your time.
Okay, So what I'm going to do is we have some questions and I will read them to you, Anoop. First of all, I want to say thank you so much for being a part of this. I had the pleasure of meeting Anoop a few years back, and we have just worked well together over the years, and I just appreciate it. I wish you would have been my neurologist way back when I had epilepsy at 15. So are amazing. And what at first I want to brag on you a little bit. Could you tell everybody about what you do and your clinic that you started? Because I talk about your clinic all the time. So that's one of my first things. He has an amazing clinic. I've actually got to see it firsthand. So could you just tell everybody how you started this and a little bit about what you do for your clinic?
Yeah, thank you, Brandy. So what Brandy's referring to is a model of care that really has been a passion of mine ever since I came to Nationwide Children's Hospital. So I started at 2010, and in 2011, a colleague of mine who's at Seattle Children's and I got together and realized we have the same vision, that we wanted to create a care model that really centered around the patient and their family, and that we create that model together. It was a year actually prior to where the Institute of Medicine came out with Epilepsy Across the Spectrum and how to deliver that care. So we wanted to create an opportunity where if the resources were necessary, they were available for that family right there and then. So we first started with a journey of putting all our epilepsy providers together in one day. And I know that seems a little foreign and maybe odd to some of you others, and especially for our new colleagues on this call and our residents. Believe it or not, that was a very foreign topic at the time. And so Thursdays became our epilepsy clinic day. Not that we don't see patients on other days. Of course we do. We see patients with epilepsy on every day. But Thursday was where we were going to just do epilepsy and everybody was going to come together. So we put all the providers together, and then we added social work. We added I'll talk about it in the order because it was an evolving process. But we started with actually social worker and neuropsychology. So we would screen all our patients, and we do still, and we're actually working on transitioning that to a better and easier screening way. But we screen patients for psychosocial issues. And then we also then employed our neuropsychology fellow to get involved if there were issues there, or our social work colleagues. Then that expanded to child developmental psychology. We actually have a PhD in psychology who's present in our clinic. Because again, many of those patients that I see are patients with significant developmental disabilities that don't really qualify under neuropsychology, but still need care and need help. Then we added pharmacy, genetic counselors, the Epilepsy Alliance of Ohio, nurses, nurse practitioners. And again, we're all one team to help that family. And so that's the care model that we developed and want and hope are going to be replicated across the United States. So it's been honestly, it's probably the most rewarding clinical success that we've had. It was a team effort. It really was a bunch of great people who are, many of them are still with us, and they're so passionate about the care we give, and we feed off each other. The energy is amazing that day. Sarita actually comes to that clinic now. So that's, I guess, the latest aspects of that multidisciplinary care model. So the idea was that our adult colleagues would come and have access to those same resources because they should. And then we're hoping to replicate those kinds of resources in their adult model. And Sarita is definitely a champion for that.
I just had to brag on that. I got to see that a few years back, and that was just, I tell everyone about that. So did you guys ever add GYN? Did you ever end up, you did?
So that is now. So the now in 2021, it was a little slow because of the pandemic, but now we're actually adding adolescent medicine in the aspects, not necessarily being present in clinic, but partnership with this Contraceptive Access Collaborative. So we have officially joined, and Neil is our champion, Dr. Kulkarni. And so what happens is, and there's regular meetings amongst all the groups that participate. And as we move forward, we're going to develop a more a better, more streamlined pipeline and communication line with our adolescent colleagues. They also employ in their adolescent medicine clinic GYN experts as it relates to that. And so it's really the next phase of how we can expand what we do. And so that's fresh and we're just 2 or 3 months in, Neil, to this. So we are the latest edition and really proud of it.
It's exciting. You have grown, and it's just a great program. So I wanted to brag on you a little bit there. So yes, start programs, call Anoop, and he will help you. Okay, so one of the questions, how do you work with caregivers to empower girls with epilepsy that have intellectual disabilities?
I think it starts with giving an understanding that these women should be treated the same way as every other patient. I know I get a little soapboxy, as my resident colleagues know, but it's really important, right? Like, we are here to make sure, and I say that right from the get-go, your child will get the same care I give every other child I see in this clinic. And so if we start there, then that starts to set the table of working together for that role. The other thing is, I think you have to be very sensitive to the fact that perhaps the transition time frame will be longer for these patients than it would be for those that don't have intellectual or developmental disabilities. What I found is those patients have a harder time, or sorry, more importantly, their caregivers have a harder time letting go for obvious reasons. We have been such an instrumental part of their life, and we've been a team and a family for so many years that it does take a little bit longer. So give them that grace as far as that goes. Lastly, I would say, please focus on those areas that are perhaps unique to this population. Guardianship. Have they thought about that? Do they have a lawyer to get that guardianship going? Have they thought about what life will look like after they age as caregivers? These are difficult conversations. Nobody has to have the answers in one day, but we have to start having those processes and conversations. So those are the things I would say to answer that question.
Okay, so do you educate these young females on the quality measures so that they know what to look for in an adult neurologist?
Yeah, I think that's a great opportunity too, because the more we empower our women during the time that we provide their care, the better they're going to be able to advocate once they hit that adult space. I guess I have this vision and dream that all of our patients are going to go out there and, demand that these things be done to their adult providers that they're seeing. Now, again, I don't have to worry about that with Sarita because I know she does that already, and I know her colleagues do that too. But obviously that may not be necessarily true for all of our patients. And we don't know if all of our patients are going to go to Ohio State. And so, yes, I do try to do that. It's nice though, because I can also share a little about the work that we do and the work that I do. And I think I've found at least a lot of the families that I partner with really love hearing some of those things. So I think it's an important and a great opportunity.
Okay, so I have a question. Let me ask you this. What do I do if my new patient is struggling with the transition to my adult clinic?
I think that's really a great question. And I wish I had a great answer. The more time we take and the more grace and patience we give, the better that's going to be. But unfortunately, I think that still remains a gap. And I'm going to tell you a personal story that's sad from my own experience. I had thought I did a great job with this family recently. It's a young adolescent boy, but the mother was the major caregiver for this child. I did all the things I talked about. I did the stepwise progression. I didn't transition until 21. I made sure all the steps were there and went over them, repeated them, made sure it was social work was involved in all the right people. And the day it happened, she looked like she had never heard anything I'd ever said to her and was upset. And then in hindsight, she came back and said, I recognize that he did tell me that, but I was just so upset to say goodbye and let go. And it was such a hard thing. That's hard for us. And so I don't know if I have all the answers for that, but I think over time, we hope to be able to find out which ways are better at doing this and ways that we can then more optimally do that transition. But ultimately, you're going to have those that struggle. And just be open and patient, I think, is the best advice I can give. And honestly, I have to learn that myself.
So I'm just going to add a question onto that. So do you recommend maybe if the child is struggling, maybe doing a conference call between the two of you to kind of keep that continuity of care still with the adult neurology, but then give that child a little bit more like, yes, I'm here for you. I'm giving you an extra boost.
So yes, but I would honestly say that should be the care model for all of our patients. And that's kind of what we're trying to do, but it doesn't work out all the way. The ideal approach, especially for that, Brandy, what you're absolutely right on is, and I'll give you an example. If Sarita's seeing one of my patients and I know they're struggling with that transition, if somehow I can be available that same day to pop in or at least introduce C.A.R.E, then I'm going to be more likely to have success in that regard. So yeah, that's an absolutely important way. You know, it's interesting because Mary Karn, one of our nurse practitioners, years ago, we were sitting at one of the American Epilepsy Society meetings, and I'm telling you, this is like 8 years ago. She turns to me and she's like, you know, we should use like video to do transitions, so that way, you know, like the adult provider could be on the screen, or we could be on the screen when they see the adult provider, so they, you know, have a better process for that. And we thought that was the greatest thing, and everybody thought we were crazy. They didn't understand how you would do that, what that is. And obviously now that's called video telehealth. So actually we're starting to look at that as a potential opportunity. But originally when we designed the transition clinic at Nationwide Children's, it wasn't something that our administration or Ohio State's administration thought was a good idea. So hence we had to get physical people over to our clinic, because we felt, okay, the first time they meet Sarita should be in an environment that they're used to and comfortable around. And that's the clinic that they've been being seen for years at Children's. So she drives all the way over to see these kids because that's what's comfortable for them. So that's another way folks can to help with that burden of transition that can potentially occur.
See, that's why we have Sarita on our board, because she's just that great of a doctor. So.
Yeah, I mean, it's unique. And I don't want to spend all this time like just saying how great everybody else is, but it's true, right? Like
Sure.
there aren't a lot of people that are willing to do that, but if it's important to them, they do. And she's not alone. She's got a lot of colleagues that come over for this, and it's been really fun we're actually expanding it because of the interest and the demand.
That's great. So this year for us, every year we choose a different topic or keyword, I guess I should say. At the end of the year, I usually choose the keyword for the next year. And it was really exciting just to hear in your talk about collaboration, because collaboration is key, is our focus this year for 2021. So thank you very much. I know that's what you do anyway, but I'm really glad to see that. Do you encourage your patients to use seizuretracker.com?
Loaded question, but great one. I do, only because of 3 reasons. In full disclosure, I am friends with Rob and Lisa Moss, who are the creators of seizuretracker.com. And other disclosures is because of my, I actually reached out to them years ago because I wanted a partner, because I believed in their mission so much. For those that are not familiar, seizure.com is the largest online seizure diary. And it's a non-for-profit that was created by Rob and Lisa Moss, who are parents of a young man with epilepsy, who's the cutest thing in the world. But anyway, so they have developed this thing because they realized there wasn't a great way to track their son's seizures online, which is a format we're all used to. So they created that. Then it evolved into apps. So an iPhone app, an Android app. And then we actually at our institution, because I was so enamored by what work they were doing, we built them the Apple Watch app. Because we felt like it was a great way for you to take your watch, go to the bedside or wherever your child is having a seizure, activate Seizure Tracker without having to leave them to go find your phone to log that information. Long story, but to get to Brandy's question, or the question that was asked, the reason why I advocate or actually recommend an online diary is it's important to get and collect what we call patient-reported outcome data. So this is important information that's out there that's being collected potentially on a daily basis that we as medical providers could have access to. I can't remember what I did yesterday, let alone what and when I go see my medical provider and they ask me questions about something that may have happened 6 months ago. So in my opinion, it's better to actually get that data at the point of time, and therefore that can be done in an online diary. The other reason why I recommend specifically Seizure Tracker is we are the first and only institution as of today that you can actually take Seizure Tracker data and view directly in our electronic health record of Epic. So we solved all those interface issues of trying to get some electronic data to talk to other electronic data. And we're now moving into a different phase of where that then data will be translated into flow sheets and available for our review. But it's really changed and improved my opportunities to interact with my families. So when they now tell me about the seizures, I visually, right here in front, when I'm sitting with them, can show and see that data through the Seizure Tracker. Sorry, it's my dog. Seizure Tracker portal that we have built into Epic. So Rob and his colleagues are expanding that to 10 other centers, hopefully by the end of this year, and not just in one electronic health record. So he's partnering with Cerner at DC Children's and other electronic health records vendors. So it's going to be something that you're going to see more and more. The more data we have and the more accurate that data is, the better we're going to be able to provide care for patients. So yeah, I do recommend it.
Do you have the, I'm sorry, my name is Deepti Zichi. I'm actually at Detroit Medical Center at Wade State in Detroit, Michigan. And I have so many wonderful comments, but no time. But do you have like the, for seizure tracker, like, do we have like validity of the data? How accurate is it?
Yeah, Rob has done some studies on that. I can't speak to them per se, but I know that he has done some validity data. And one of the things that and it is a gap that we should probably still try to work on closing. The data is obviously better for those that start using seizure tracker earlier than later. Over time, the validity of that data wanes, and it's likely because people don't continue, or perhaps they're having less seizures. We don't know. But Rob has done some of that. And I forget his, Dan Goldstein, I think. There's a colleague of his that works in the East Coast, Brandy may know, that has published on this area.
I can actually connect you with him. So full disclosure, when I started the My Epilepsy Story, Rob and Lisa, I just got to know them personally just because we were advocates. And originally our organization was for women and children. And we streamlined a few years ago and went to women and girls. So we had to kick Evan off of our website. And I love their family. And we actually are partnering with them quite a bit. And I'm a huge advocate. I will tell you personally, as a person that has epilepsy, I wish this would have been around for when I was younger, because as you know, Anoop is saying, if we start this early and embed this with these kids to use this on a regular basis, whether you're having a seizure or not is very useful. And the problem is, as an adult, I was not trained to use seizure tracker on a daily basis because I'm not having seizures. So if we had that, that would have been very helpful. So I think that we need to ingrain everyone. It's a lot harder to get the adults to start using it, but we should. We need to get these women, and they have a series that we're working with them on as far as the female aspect for birth control and stuff like that. But if you can train these younger kids to really start using it on a daily basis, regardless if they're having a seizure or not, that is extremely important. And that helps with that data collecting long term. So
yeah, that'd be great. Yeah.
And I would argue that the data that you get in seizure tracker is it any better than what I get in my daily visit? Like, has anyone really know how accurate somebody's report?
Yeah, there's no comparison really. Right. There's no way to validate it.
Right. I mean, it's a gap for everything. And so, unless we start getting good automated seizure wearables and devices that track seizures accurately, then that's really going to be where we get true counts. But right now, I think it's as good as what we do now.
And I think that one of the things with them is they have a personal story that they're embedded to make this better for the community as a whole, which is why I love them. And like I said, we've partnered with them and just know them on a personal level for so many years. But I always bring that up. So that was really my question, because I want everyone to know about Seizure Tracker. It's seizuretracker.com. So make sure you share that with all your patients and have them, you can even have them download that app. Of course, everything is virtual right now, but when you see them in person, you can even tell them virtually, hey, let's go ahead and just download this right now. And then they can start that process of filling everything out. And then it actually helps you, like Anoop was saying, as a physician, to be able to go in there and look at their stuff.
Yeah, it'd be great to connect with Robin, see if we can get that, because we have Cerner, and that would be great to implement that and get that data into our
if you send me a quick text or an email, I will definitely connect you.
Yeah, definitely. I think it'd be great to have him give us a virtual presentation, convince the rest of my group and maybe even the pediatric folks to get this going.
Yeah,
but I'm very jealous, Dr. Patel, of your setup.
Yeah.
No, well, I mean, thank you, but the goal is really for everybody to have a similar setup. It's not that it has to be at our center, or you have to come to our center, because that's not feasible for everyone. But the last thing I'll say about online diaries, no matter which one you use, don't use it in isolation, right? So for the medical providers, use it in conjunction with your questions that you ask and help validate the responses that they're given. That's, again, one of the greatest things about me being able to visualize. I can now say, well, it looks like the last seizure, so-and-so had was March 18th. Is that right? Oh yeah, or no, I entered that wrong. I mean, you can validate that, or at least reinforce it during your office visit.
Yeah, sure.
And Deep, the one nice thing you're going to love about it, if you do partner with that specifically, is what Brandy mentioned is made a lot easier. Because right now what happens is if they're let's say they're not a seizure tracker user, is that we can send them an email from Epic, our Epic, or your electronic health record would be Cerner, he's working on that. So then they can activate that link and automatically the permissions are granted. So, we don't have to wait for them to download, or we don't have to, show them where it is on the website. You say, hey, let me just shoot you an email real quick from the EHR, and boom, that link is there. It'd be great to partner with other online diaries, but right now I feel like they're the ones that are the most developed.
And I'll also say with theirs, they keep updating. A lot of seizure diaries that are out there, you see them and they become outdated. And so the user starts to use them and then things just kind of fall to the wayside and it's not a current update. And Rob Moss is very on top of it and he wants to make sure it keeps, so he's always updating and making sure he's staying ahead of the game.
Right.
So that's one of the reasons I recommend it. So
Dr. Patel, can I ask one last question? Sorry, Dr. Patel, can I email you and just reach out to you and have separately? Is that okay? And I'll bother you there. Okay. Yeah, I know we've gone over 9.
Oh, no. We still have like 30 minutes. A few more minutes.
Yeah.
Okay. Oh, I wasn't sure. Okay, I thought it was 9. So how did you get the hospital to buy in and put money into like the social worker and everyone, and then everyone is there, and how are you billing? Because we're tenant owned. So if it's profit, and so we've been begging for a social worker for about 9 to 10 years after they removed it. And we're really struggling. How do you get the buy-in?
Yeah. And I'll be honest, you're not unique in that regard, and it's tough, but, partly I will answer because I'm very lucky. I'm lucky to have administrators and folks that, understand the mission and the vision as far as it relates to that care. We also tied into quality measures. So one of the better ways to get those is, first of all, make sure you highlight the national collaborative opportunities as it relates to these quality measures and what resources are necessary for you to be successful in implementing that. So that's one way you can advocate and help with other resources for that. The other thing is start looking at impacts on utilization. So from a billing standpoint, because of the use of social workers, we just looked at this and are working on a manuscript, is when social workers actually reached out to our patients who are at high risk of no-shows, they started showing up. So that's revenue now you're capturing, and that revenue outpaces the salary of a social worker. So unfortunately, our social work colleagues don't make nearly enough. But that is okay for us. It's not okay for them, but it's okay for us because it doesn't really take that much before that return on investment is there. So you start tracking your data as it relates to that opportunity. And lastly, we have the benefit of being part of an accountable care organization. So I tied social work care to healthcare utilization. So healthcare utilization in our institution, in our fee-for-service model, is made based on numbers, right? So the more kids I see, or the more kids that show up in my emergency department, or the more kids that show up in the hospital, the more money my hospital makes. Well, that seems pretty backward as far as what we should be doing, right? Like we should be keeping kids out of the hospital. Well, if you're part of an ACO, which means you're responsible for that healthcare and you're also responsible for the bills, then saving or keeping kids out of the emergency department now become a revenue opportunity. Luckily, we are part of an ACO, and so over half our population is part of that ACO. And so I always tell the story when I went to who now is our chief executive officer, but at the time he was our chief CFO. I said, hey, Tim Robinson, I said, I just lost you $1.5 million in revenue because of the efforts that social work, the team did on QI. And his first answer was, that's awesome. We got to be doing more of that. And it's partly because he cares and he's a good person and does the right thing. But more importantly, he's a businessman. And so we had to frame it in a way that it resonates for him. And so those things resonated in that aspect. It's not an easy journey, and those aren't easy answers by no means. And honestly, look how it took me a long time. So the last thing I'll tell you with that is just keep bugging them. Don't keep persisting. I told them, I said, listen, they said no to my second social worker year after year after year. And I said, I'm never going to stop. I'm going to ask you every year. But I just had to frame it. I had to position it to where it's a story told by their lens, right? Like, know your audience and know what resonates with them. And I know that sounds kind of weird, but right, your administration is like any others. They're looking at the big picture, and everybody's asking for everything. And why should they give it to you? So if you frame it in those aspects, you may be more successful. But it takes data, and QI is a great way to get there too, by the way. But that's a separate presentation.
I will tell you, Deep T was one of our Matter Award recipients. So I'm really glad that she's here tonight. So hey, Deep T. She's an amazing doctor. Okay, I've got some more questions. Here we go. Sarita says she completely agrees with us. Do you feel like counseling is more difficult in the teenage years, as they often feel accompanied by patient caregivers? And how do you navigate that conversation? I'm assuming, Sarita, you may want to chime in on which portion is, sorry.
Yeah. So specifically with contraception, like I feel like on the adult side, there's no one with them. So I can talk about being sexually active and what contraception needs. Are they wanting to get pregnant? But I just feel like even when I'm in the transition.
You're muted.
Oops, sorry. Even in the transition clinic, I'm like, asking these questions, but I'm like, oh, can I, ask anything that are you okay with mom and dad here, that I'm asking about a lot of these questions? I just feel like it's so much harder than my adult clinic when they just come alone and I can, literally ask anything I want.
Yeah, you're absolutely right. We have to get better at that. And that's part of the reason why we're doing that contraceptive access collaborative. So the idea behind that is, let's create talking points that we're all comfortable with and that have been used in the adolescent medicine clinic that can be used in our epilepsy clinic. I will say right now, sometimes either I'll have the mom or dad leave the room so I can talk to the adolescent by herself. But I've been trialing this lately, but I've just lately been just doing it, just talking about it,
Yeah.
And the more I'm comfortable, the more they're comfortable, and honestly, it's pretty awkward when, a male pediatric epilepsy provider is talking about birth control. But what I start with, and I don't know if it's going to work, I'll follow up with you as I, do this mini experiment or PDSA. I kind of just, say, I just think it's important. We're just going to talk about it, and just say, it's important, right? And then let them kind of whittle and stuff. I have had one mom say, well, that's just rude because it's not important to my kid. And I said, okay, but again, I don't pass judgment. I just come in saying, I don't know, I'm just doing it. But I do feel, Sarita, you're right. And we should partner and work together on how to improve that, because and Neil's going to champion that. I mean, Neil's going to be hugely involved with that. So maybe we can get you involved with that aspects of those talking points.
What age are you starting to have this conversation? Because I know we used to sit on the same measures here, and we talked about this a little bit. What age do you start having that conversation?
So if they're having their menstrual cycles, that's the first question. Are you having your menstrual cycle, or is your child having a menstrual cycle? And if the answer is yes, then yes, we start having that conversation, believe it or not. And again, it starts with the folic acid and the counseling piece, right? Like, so that part now is done by our nursing. And so by the time I get them, it's just about folic acid. So it's like I've already gotten that step out of the way. And really, this is literally in the past month or two I've started this. So by no means am I an expert in this area, but then I'm like, well, have you started thinking about birth control? And do you want me to refer you? And I tell them why. I say, I have this great colleague in their clinic, and they're really working on these issues. You may not be on birth control, but some of the birth control that you may want to take could interact with your seizure medicine. And so, please let me know, keep an open mind. And again, I use that term all the time. And I'm not here to judge. I'm not saying anything or advocating. I'm just saying that we have to understand everything and ask all those questions. So
I'm gonna chime in. So I'm, the patient advocate and the parent side point. So, and we've had these discussions, Anoop on some of the calls that we've been on, and Sarita on some of the things, this is such a touchy subject, and we know it has to be addressed. And so, even as a board, we've kind of talked about this, like at what age do we start talking about some of these topics? We know they need to be addressed, but at what age? And now, so for me, I'm a mom of a teenager. I'm like, we're never talking about this stuff, right? So I think that, it's such a hard thing, right? Because we want to make sure we don't miss some of these girls that really need this extra, I would say, conversation, probably, that are not getting it at home and probably do need to get more. But I also think that there's a fine line from the parent's perspective, because I feel like you're going to turn off some parents and you will lose them, which will ultimately you will lose that child. And so I feel like there's, me personally, I would hope that doctors would come to me and say, hey, we just want to let you know we were going to have this conversation. Are you comfortable with that? And I think that as a parent, to me, that makes me say, hey, I'm going to trust you alone with my child, because if somebody doesn't tell me that, I'm not leaving the room. Now, I have a pediatrician that we've trusted for years and years, so I would leave the room. But I think when you're in this teen age, so I'm just proposing that really that you have that conversation with the parent first and say, hey, I just want to give you a heads up, or I don't know, even a questionnaire that you give the parents maybe at the same time you're giving the kids. And then just say, well, is it okay if we go ahead and have this conversation either with or without you, and give them an option, so that way that they feel that they're a part of that. Because I feel like if you lose that parent, you've lost so much at that point.
Yeah, that's a really great suggestion, Brandy. Thank you. Yeah, that's a great. Yeah, I'll definitely, Neil, we should take that back to the CAC, because that's a really good, these are good ideas.
I think that
Agree,
works
kind
when
of
they're, I'm sorry, guys. I think that when they're, especially when they're young, like 12 or 10, and they're hitting puberty. When they're older, they don't feel comfortable. You can see, and so I kick the parents out. And they lie. And if you ask in front of the parents, they lie, and then 2 months later, they're calling you that they're pregnant, and you're just like, oh my God, did I prescribe folic acid, and what happened? And you're just like, oh God. So yeah, it's a balance.
Conversation when they're younger. I mean, obviously,
Yeah,
some of these,
especially when they're younger. Yeah.
Some of these girls you're not going to get until they're, in the teen years anyway, right? But let's just say if you
Yeah.
had a girl that you've had as a patient for a while, just starting that conversation with that parent.
Yeah.
Even I think just the parent, like, hey, I need to really start having some of these conversations, and maybe having my viewpoint or what I want for my child to take away from sexual health or whatever. What is our family view? And we want to have that conversation before they get it from the classmates, or what I mean, the doctor. And so even when you start to give that parent a little bit more of that control, they can actually start to have that conversation, and it's not a threat.
And perhaps you're both speaking to the point that it's so important to have these conversations early, so that way parents can begin to have agency in the beginning. You've developed trust with them, and then you can also then develop trust with the child, and then later on everyone's okay with the mom being out of the room. And thank you, we really appreciate this feedback, because it's a completely different point of view that we need to be mindful of when we're giving this counseling, to make sure that it's received by everyone. And because parents are the rulers at home, so if they're on our side for getting folic acid to these kids, it's going to be a huge help.
So
and I think that I'm sorry.
No, I was just gonna say, I think if you could get those, even like, when you're having the paperwork, when you start doing that paperwork stuff, even if you're giving a set to like, for instance, I'll give you an example. We were transitioning over to a female pediatrician with our daughter, and we'd had the same pediatrician for years, and she was just, in that, she's 12, like, oh, maybe I should see a female. And so I thought, okay, we're going to transition. Well, we hadn't built any trust, and the pediatrician said, okay, well, you're going to have to go ahead and step out of the room the next time. And I thought, oh, hell no. What, like, what? And so now she's in the same practice with our pediatrician. So our boys continued with, and I said, oh no, we're switching back. So we switched back to the male pediatrician because of the fact that at that point we hadn't even built a trust relationship. And so I was like, I don't, she might be a really great person. I mean, I have no clue, but at that moment I was like, no, you lost me. We're done. And so I think that's really, so even if you start, which, and Noop, we've talked about this before, right? When we've done some of our Academy of Neurology stuff, is at what age, right? Everybody's like tiptoeing around. At what age do we talk about these things? And really, I think those conversations need to be with the parent at 8, 9, 10, because we're prepping for the next couple of years, right? And so now obviously that's totally different when you get a teenager. Like I was 15 when I developed epilepsy, totally different ballpark. But I will tell you, again, the pediatric neurologist lost my mother because when they said, oh, we need to go ahead and send her to a gynecologist. And my mom was like, absolutely not, because that means that in her mind, that means like, well, you're okaying for her to go have sex, which was totally crazy, right? But again, you're getting into different viewpoints. And I grew up in the South, very, very conservative. So that's kind of the mindset. Women's health was just a totally taboo topic. So I think we've got to somehow get this balance. And I think that if we could get them younger, and then if you happen to capture these girls, like for me, when I was 15, build that trust with those moms, because you will get a lot further. I don't know. So sorry, that's my.
No, that's good.
I agree that starting early is so important. What do we do though when we have, when we don't have that luxury? Like we have a 14, 15-year-old patient and she's brand new to us and she has epilepsy. Now, I'd like to specifically ask you, since that's your, experience, would you have been okay with your mother being there when we're talking about this? Would you have lied, or would you have wanted your mother to be outside the room? And I don't know the right answer to that. I'm sincerely curious.
Yeah, so it was interesting because they actually sent me to GYN because I was on valproate, right? Not having a cycle. They're like, we got to get this fixed. And so GYN was like, you got to go. They were pretty much like just putting the hammer down, like your mom's got to get out of the room. I mean, you see, it became a battle. So then it actually put me as a 15-year-old in a really awkward position, because then I knew I was going to have to deal with my mother, right? What happened in the room. So I think I would say that if you're getting a patient, very similar situation where I was 15, I would really, again, have that packet or paper that you're going to, let's just say you call it your sexual health paper. I don't know, whatever you're going to call it, that you're going to give to that parent. And not per se, they each have their own, right? So the daughter has a set, and then the mother or father, whatever, has the conversation paper. And then you know what you're getting into before you actually enter that room. And so I think that gives you a little bit of an advantage of where this conversation needs to go. Now, does that mean that you probably won't be able to have that conversation the first go round? Probably not, because you're not really going to know. You haven't built that trust. And so pediatrics, you're in a little bit of a difficult situation, right? Because this girl could be out having sex. So we don't know that. But on the flip side, part of me is, if you could build that first few months of trust, what are the chances that she's going to get pregnant right away in those first few months?
She does.
All right, Deepti.
I had a 16-year-old because they were worried about catamenial epilepsy. So the pediatrics don't want to deal with it. They send all of them to me. Mm-hmm. But, I think that one of the good ways to get around it is, if you're not able to treat them at that thing, what I do is I talk about women's health and pregnancy planning in the future, as if they're going to have babies later on down the line. And it clicks with the parents. So like, hey, you're going to have babies. And, half of them think they can't have children because they have epilepsy, right? Because they're still being told these kind of things. So that just kind of opens their mind to that, and then just say, yeah. And so what we do is we prescribe folic acid to all of our young women. And now I joke around if I can joke with them, I say, and all of you lie, you all lie to me, and they all laugh and they're like sniggering, but then the parents also hear it. And then they're like, okay, let's talk about this conversation. Sometimes the parents are like, oh, so we should talk about birth control. I'm like, yes, let's talk about it. But you're right. You have to play it by ear, but education about like future pregnancy may not be a bad way of segueing into, well, what are you doing kind of a thing too. This is just what I do with my younger ones, but.
I was going to say, Anoop actually just takes, I'm just going to say this. This is something that Anoop does. And we talked about this in the video that he did for us a couple years ago. He pretty much, folic acid is just part of your regimen. It's like a prescription, right? So I'm giving you, I'm going to say Depakote, which we don't give anymore, so let's not even use that. But I'm giving you Keppra, and then I'm also giving you folic acid, and it's a prescription. It is what it is. So then it becomes, I'm not really necessarily talking about that topic right at this moment, but I know that they're taking it. And so when you can get to that place, but I love how Anoop has always, I'm gonna say always, but I'm assuming he's always approached it that way because I know he's done that for as long as I've known him. So I think it's a really important thing because as a teenager, I was never given folic acid. And so that was never even on the radar. And I think now over the years, folic acid, it's like, oh, you can just go buy it at the grocery store, but I really believe if we get the prescription thing, so I would suggest going Anoop's route because it's a prescription, you gotta take it.
Well, and thanks, Brandy. And I said the other benefit of doing a prescription, and Neil knows this, and actually Whitney, I'm sorry, Whitney's been involved in these projects too. I don't want to minimize that. But one of the nice things is if you do a prescription, it's easy.
You can all turn on your cameras. You can totally turn on your cameras. Sorry.
But it allows you to track it better, right? Like, so I have a better way of knowing, at least they're getting the prescription. Now, whether they take it or not, I think is still an opportunity. But Neil and Whitney, but Neil, because Whitney's going to be graduating, maybe Brianna wants to take over for Whitney, by the way, for her, the project. But we could incorporate these ideas in that assessment, right? Because we do the on the front end with the nursing, and that could be potentially built in, as we roll out our work with the Contraceptive Access Collaborative. And then, I think the other last thing I'll say on that, and I know we're about out of time, is I think we have an opportunity, and I know Neil will do this, but learning from the best practices of our adolescent medicine colleagues, they probably know, I've studied some of the best ways to deliver some of these messages. And they may be unique in our epilepsy clinic, but perhaps there's some learning opportunities, and we got to learn together. So I love all this dialogue.
I agree. This dialogue is so important because, things that you're very strong at and do all the time, we can certainly, adapt some of that to our own discussions.
Yeah, well, feel free to reach out. I mean, like, I can offer the parent perspective. I have a child that has autism. He's a male, but I can offer also the perspective of dealing with a parent that has a significant disability, what that looks like. Because let me tell you, that was a really hard thing as a parent to come to grips with as well. So, there's a difference. Feel free to call me or text me or email and say, hey, I got a question. Like, how should we approach these things? But I do want to say, Whitney and Brianna, thank you so much for all of your work. You ladies have been really instrumental for helping us. And I really do appreciate everything you do. And thank you, Anoop, again, for everything. Very thankful for you and all the work that you do. I'm just amazed. I sing your praises all the time. So thank you again. And if you have any other questions, you can feel free to shoot them email to me or even email Anoop. If you don't have his email, I can always connect you guys and we can talk more. But thank you again. And thank you Nationwide Children's for participating and sponsoring MES and young women with epilepsy. Thank you.
Thanks, Brandy. Everybody have a great evening.
Hey, Dr. Patel, I wanted to talk to you about one thing real quick.
Yeah.
I just wanted to, it's funny that you mentioned that new clinic that you're having with the adolescent side. So we're starting epilepsy AYA clinic with our MedPeds group. So I wonder if we could collaborate, me and Neil, in the future, just to throw it out there because I have you here.
Yeah. So yes, this is now like a local brainstorming session, but so reach out to Neil sooner than later because Neil is leading our efforts with the partnership on the CAC. And Elise is always looking for that this could be a really cool model. And Neil's actually going to be presenting in August at the CAC about some of our efforts because our goals were we had to get good about counseling and now we have to get good about folic acid. And then we're going to start getting good about talking about contraception. And so there's like this kind of stepwise. And then obviously the ultimate goal is decreasing unintended teen pregnancies and also harm to babies born. And so one of the opportunities that we're going to need to do is partnering with our adult colleagues, because once we do that transition, we got to make sure those habits continue, and we can track that moving forward. So yeah, reach out to Neil sooner than later so we can get you in that.
And then Neil just said nutrition. So it's interesting. So our organization, I'm just gonna say this. So I, when I started this, obviously it was because of Samuel. I took a medication and it impacted him. But I really started looking about what did I not get as a teenager and not into adult, young adulthood. And so then that's really kind of where everything has kind of encompassed from. And so Neil was talking about nutrition. So I believe that when you talk about exercise, nutrition, it's not epilepsy that we just focus on, it's the whole woman. One of the things we focus on is like relationships, right? Are you getting into great relationships? What does that look like? Finance, because a lot of women that have a disability or epilepsy, not even that so much as a disability, but just they tend to get in bad relationships because they have bad self-esteem. So then that causes this cycle effect as they get older, which will then make them more vulnerable. So it's just so many different aspects. So we want the woman as a whole to be great, which ultimately will impact her epilepsy in a positive way. So
I love it. All right, everyone.
I can't
Okay,
wait.
Sarita.
Guys, thank you so much, everyone. I'm sorry, do you guys have something else?
Oh no, just saying bye.
Bye, everybody. Thank you so much.